Welcome to Complicating the Narrative, a podcast that takes on the challenging questions in public health by embracing complexity rather than avoiding it. I'm your host, Salma Abdallah. In 2024, U.S. life expectancy ticked up to 79 years, and a lot of people were relieved. Finally, we're seeing signs of a rebound. But what happens when you look at the same question through different types of data and different comparisons? Asking not just how the U.S. is doing relative to its own past, but how many people are dying here who wouldn't be dying elsewhere, or who specifically is bearing the burden of premature death in the U.S. When you ask these questions, the picture changes. The tool at the center of today's conversation is excess mortality, a way of estimating how many deaths exceed what we would expect under a different set of conditions. It's a method my guest has been using to ask broad questions about American mortality for years. Andrew Stokes is an associate professor of global health at Boston University School of Public Health and director of the Uncounted Lab. He's a demographer by training. In this conversation, we work through three bodies of research of his. The original Missing Americans work, which asks how many people in the U.S. die each year who would have survived if we simply had the mortality rate of peer nations. We also look at the COVID-19 pandemic mortality gap, and we look at a recent paper examining excess death by educational attainment in the United States. We also get into what GLP drugs mean for public health research and public health practice. But running through the conversation is a question about perspective. Demographers are not epidemiologists focusing on isolating causes, and they are not clinicians weighing treatment for individual patients. They are trained to look at populations across time. That framing turns out to matter a lot for what you see. Andrew, welcome to the podcast.
Thank you for having me, Salma.
So the first question, I guess, and maybe we'll just dive into it immediately, is what's an excess mortality statistic and why should we care about it?
Thank you for the question. So excess mortality tools have been around for quite a while, even before the COVID-19 pandemic, but their use became much more prevalent during the pandemic period just because assignment or attribution to COVID itself was either delayed or incomplete, and we needed other techniques to capture the full effects of the COVID pandemic on mortality, both through direct mechanisms as well as through indirect mechanisms. So it became a very convenient tool during that period, and it turned out that it resonated with the public and it was something that people could understand.
And so that's the public, and I think that's great. And I also think I reading more about your work, it seems like, as you said, it is a very translatable, accessible way of describing general changes in a system. But as someone who's a demographer, who's also an excellent public health researcher, and Andrew is my colleague for a few years, so I know when students say, like, Andrew just teaches everyone the best statistical methods to think about a public health issue. What are the benefits when you think about excess mortality as a tool from a public health research perspective, but also what are the limitations?
I think the benefits are that it asks us to think carefully about potential counterfactuals, whether that's the continuance of pre-pandemic trends or other applications of the model, such as, what if the U.S. had the age-specific mortality rates of other wealthy nations? So there are a number of potential counterfactuals that can be used with an excess mortality framework, and it allows us to imagine other hypothetical worlds. The limitations, of course, are many, including that we have to make assumptions. For example, in projecting expected mortality during the pandemic to calculate excess mortality, which years you used in that pre-pandemic period really mattered. So if you extrapolated trends from 2015 to 19 and projected that forward, it led to different results than incorporating earlier data.
And I think that was reading through your papers, and we go through them right now. I saw there's a benefit, but also the struggle for me, because I think it is a blunt instrument. It tells you something general about the population, but also at the same time, it is a blunt instrument because it doesn't necessarily tell you exactly like what is causing some of the issues we're seeing, or like what specific causes of death can you actually attribute to what we're seeing. And I think as we dig deeper into the Missing Americans paper, also the challenge of what do you pick as a comparison. And we're all, as scientists, of course, then affected by our biases of like, what do we think is a relevant way to pick a comparison group and a comparison time period? So I think those are the two things I was both trying to think about as I was reading your papers that I found to be very helpful. But before we get into that, I know you actually label your lab now, or the lab name is Uncounted Lab. Is it because of excess mortality? Is that something that you're going to focus on in the future, or does that also include other things?
Well, I think, and thank you for this question. As a demographer, the use of mortality statistics is kind of something that we take very seriously. We make a lot of use of these data, but we also recognize that these data are imperfect and incomplete. And so, in my training and as an assistant professor, now an associate professor, I've given a lot of thought to how we correct and improve the utility of mortality data, taking into account these potential biases and undercounts.
Yeah, and I think so. Is there another limitation? I was trying to read online to see everyone who critiques using excess mortality data to see like what are still manning some of the critiques that people provide. I think some of it was lag in reporting, but to be honest with you, I will let you speak more about it. But I'm not sure that that just applies to excess mortality data. So that's interesting to me that that's something people flag. But I would have said that applies to a lot of population health indicators. So I'm not sure it's just necessarily an issue with excess mortality. What do you think about that?
No, absolutely. And in fact, the excess mortality modeling helps us to get around some of these undercounts of specific causes of death. COVID was a case where there was incomplete reporting, but there was also biases in the attribution of deaths to COVID. In some states and counties, there was even a refusal to attribute deaths to COVID due to the COVID denialism. And so in cases like that, where you just have really incomplete reporting for whatever reason, it's important to develop other ways to circumvent that using this excess mortality modeling framework.
I think then this is a really good segue then to the first big paper that you've created, or at least the one I found. Maybe you've had previous papers about this, so correct me if I'm mistaken, but the one that I think brought a lot of attention to the work you're doing, which was the Missing Americans paper that was published with colleagues, including Jacob Bohr, who's an amazing colleague at BU, looking at excess mortality in the US through the decades, comparing it to other countries. And I believe it was published in PNS Nexus. So can you tell us a bit more about the paper itself? What was the design of the paper?
Right. And so Jacob Bohr gets a lot of credit for this, and I've appreciated his collaboration over many years. I think the idea of the Missing Americans work, and it's a portfolio with several parts to it, is that using an internal comparison for evaluating U.S. mortality trends can be problematic insofar as we are all kind of subjected to the same built environment and the same factors that are adverse to our mortality levels and health. And so, for example, our food environment in the United States, some groups are more subjected to it than others, depending on where you live and your socioeconomic status. But to some extent, we're all affected by the U.S. environment. And so the idea of the Missing Americans work is to use an international counterfactual, which puts U.S. mortality trends into a new light, where all of us, by race and ethnicity, by SES, we all suffer higher mortality rates than our European counterparts.
I think just going a bit more into the design, my understanding is you selected a specific set of countries in Europe, and the first years to start looking at was the 1930s all the way then to 2021, right?
That's right. And we find this really remarkable crossover around the early 1980s, where the US mortality advantage reversed and became a disadvantage, which has essentially grown in every year since the early 1980s,
Hmm.
culminating during the COVID pandemic period, but continuing full speed ahead as of the most recent data in 2023 and 2024.
Yeah. And before getting into the results of the paper, just thinking about the comparison group, I think because I'm really trying to conceptualize excess mortality in my mind, I think the first thing that came to mind is that you thought really hard about which countries to include. Like I was looking through the criteria, and I think you took out some of the Eastern European countries for specific reasons, and then you also took out, if I'm not mistaken, Australia and New Zealand. So can you tell us a bit more about like what led to the criteria of which countries to include as a comparison group versus not?
In general, it's a fairly arbitrary decision, and the results definitely differ based on your comparison set. Classically, some comparisons have been made historically to countries at the frontier of mortality and longevity, countries like Japan, countries in Northern Europe. We chose a more modest benchmark, which is the average of other wealthy nations. And we essentially tried to include all other wealthy nations for which data were available for the full time series. Our approach was just to include all the possible data and then kind of take the average as the benchmark, which is to say that we're setting modest expectations for US performance because we're not saying the US has to live up to Japan or to Norway, just to the average of other wealthy nations.
And I think that's actually also a helpful way of saying like, we were not trying to either inflate or deflate some of the findings that you have. Like we were just trying to say, this is like, if the bar is like lowered as much as we can, what still can we get comparing the US to other countries? I think what was striking to me, first of all, that the US had an advantage, if I understand correctly, from the 30s to the 50s, and then that continued to disappear, but also from some of your findings that, as you said, the excess mortality kept going up and up until reaching about, I think, more than 600,000 in 2019. And of course, it just exploded with COVID up to more than 1 million 2020 and 2021. I think, but also what was interesting there is that it wasn't just among those who are older. You were seeing excess mortality among younger people. And I was also wondering if that was a driver to thinking about some of the papers you had after that specific seminal paper that you had, because those were interesting findings for me.
So, nearly half of people under age 65 in the United States are missing Americans, meaning that most of the premature mortality that we face in the United States today is avoidable if we only had the levels of mortality uh, of other wealthy nations. And so there really is a crisis of premature mortality that appears preventable. I think one thing that happened in the follow-up paper that was interesting is that we saw that missing Americans or U.S. excess mortality relative to other wealthy nations continues to grow at a fast pace, even in recent years. And so when we got the new numbers for 2024, there was slight improvements in mortality and life expectancy, and a lot of commentators had a lot of optimistic response to those trends and said, "Oh, good, U.S. mortality trends are improving. Finally, we've experienced a full rebound from the COVID pandemic." But in this international comparative perspective, the outcome is a little more grim because relative to other wealthy nations, we're continuing to face greater and greater excess in each year and diverging from their experience.
Yeah, and I think also relative. Like I think you've spoken about this publicly as well, because like there was a big excitement in there that the U.S. reached 79 life expectancy, and people were excited in 2024. And then it was helpful to just say, "Oh no, we can if we compare to other countries." It means actually we're not doing as well as we could. And I think also from your paper, I don't know if that's the same paper you're talking about, the one in JAMA Forum. I think you show that even compared to 2019. The US in 2023 was not doing as well. Like I think it was about like 725,000 people missing Americans in 2023 compared to 600 in 2019, which is exactly what we're saying. So it wasn't even just compared to other countries. It wasn't comparing even to pre-pandemic. We're still doing worse.
That's right. There's several components to this story. There's a long-running U.S. mortality disadvantage that's growing each
Yeah.
year, but there's also the scarring effects of the COVID pandemic, which have left a long tail in terms of their direct effects of the SARS-CoV-2 virus, but also the indirect effects on occupational and socioeconomic displacement.
Yeah. And I know you're a data person, so you might not want to answer this question for me, but I actually think a strong reason why some of this work got traction was you called it the missing Americans. So before we move on to your next work, I wanted to ask, do you think calling your paper the missing Americans was actually a helpful way to bring attention to this work? And where did that term come from?
Yes, I give Jacob Bohr and his colleagues full credit for the term that goes back to a early Lancet collaboration that he had before the pandemic. So I can't take credit for the term, but
Okay.
I certainly have observed that it's resonated and it's been an evocative way to capture this for the public's attention. And hopefully we can continue to work on this agenda and kind of dig into the causes of death that contribute most to missing Americans in the United States, so we can really understand the mechanisms and what's creating this disadvantage.
Yeah, and actually, this is to me, it was very helpful to see one of your recent papers, which I think is trying to get into that, trying to understand at least what seems to be the educational gap here. I think in the Missing Americans paper and subsequent papers, you talk a bit about, generally speaking, what are the issues you think might be leading to some of the numbers we're seeing. But this more recent paper, I think it was in JAMA Open. Again, I could be wrong, but we'll put all of those papers on the show notes. you actually looked at differences by educational attainment. So in the US, people who have a college degree, which is a new pet peeve of mine. So we actually had a paper come out in Lancet Americas earlier last year looking into cardiovascular disease outcomes in the US by educational attainment. Because, for example, I do think that education is becoming a really important signifier in this country. But this paper tried to look into excess mortalities in the US or excess death, comparing people who have a college degree versus not. So do you want to tell us a bit more about that paper and what did you find?
Sure. Thank you for your interest. And, Salma, your work in this area has been very inspiring to us. You've long looked at cardiovascular trends stratifying by income and education and other factors, and that's really revealed the great extent of these disparities for cardiovascular disease. So that's been very interesting and relevant to our research. What we did in this paper is, instead of using a international counterfactual, we asked a different question. We said, what if mortality trends had continued from the early 2000s when we were on a better track? And if we had extrapolated those throughout the 2010s when mortality started to stagnate, how many people would be alive today who were otherwise dead? And when we stratified by education, we found that most of the excess deaths that occurred over this period were in those with less education, the lion's share of them, unfortunately. And this was a two-part story around cardiovascular deaths, as you've noted in your research, as well as deaths of despair. But, between those two sets of causes, while deaths of despair, have captured a lot of attention, unfortunately, the cardiometabolic diseases do contribute much of the burden on an absolute scale.
Yeah. It was mind blowing to me. I think in 2023 there was more than 500,000 excess deaths, and about 90% occurred among people who don't have a college degree. And I know those are a lot of numbers for people, but you look at the paper. More than 56% of the cause of those excess mortality was actually cardiometabolic outputs, or outcomes, which is fascinating because it is really important. And I think about 13% was due to opioids and other external factors. So I'm really trying to think through. I have a few methodological questions, but generally this big picture, this made me think I'm hoping to write a piece one day. I don't know also what you're taking this research forward, just to say framing matters. Like I think you saying missing Americans matters, similar to when people started saying death of despair, that created a narrative for people to think about it. But at the same time, I'm increasingly fascinated with how long does it take for an understanding of an issue to change within public health research. Like I am actually wondering if someone is looking into this, and please let us know if you are, where at a certain period, people thought a certain framing is important, and then people continue to just do confirmatory research about that specific issue, which then led to us not really thinking about like other issues. For example, people started thinking about deaths of despair, which are really important, but then not necessarily thinking about other issues. And I don't necessarily know what would be a solution to that issue. I know there is a recent paper that, like, there is a group, if I'm remembering correctly, in Tufts and other universities who are trying to look more into causes of death in the US and increasingly highlighting cardiovascular diseases. But I don't know what do we do to help focus on cardiovascular disease more. We just keep doing the type of research we do, or does it require having, dare I say, just like a sexier way to it? Because cardiovascular disease, cardiometabolic, it's a very hard thing to get people excited about. I don't know what are your general thoughts about this type of work?
Yeah, I think that's absolutely true. And when Case and Deaton and others developed this framework around the deaths of despair and talked about this natural grouping of causes, which might reflect deeper structural problems in society and economic dislocation, it really did resonate, and it created, a whole decade of research after that on those deaths of despair, with comparatively much less research on cardiometabolic causes of death.
Yeah.
And so, there's been a few groups looking into those trends and their contribution to stagnating mortality in the United States, but it's received much less emphasis.
Yeah. Yeah. So then I think, not a pet peeve, but I was very interested, maybe because I'm also interested in education among women. In your paper, we have the table. We can see the excess death specifically for total males, total females, males without a bachelor degree, males with a bachelor degree, females without a bachelor degree. But then when you get to women like me, who I might be very much interested in, females like me, it all says NAs. So I was trying to understand what was the methodological design for that. There's, of course, a reason, but I was thinking if I was just reading this very quickly, I wasn't a public health person, I would be interested to see like the NAs.
So We have NAs in the last column where we're
Yeah.
decomposing by cause.
Yeah.
And that's because for all causes, the number of excess deaths is negative. So that
Okay.
negative value would be difficult to decompose.
Yeah. Yeah. Okay. That's fair. Okay. I just wondering. So then I think just thinking a bit more about this specific paper and just generally also looking at this work. And I know you try a lot to focus on the structural part of the equation that leads to some of the excess mortality we see. Do you think there is a danger for people to say, well, maybe those educated people should just do better? And also, when you're looking at education, are you thinking about it as an approach for people to have more knowledge so they improve their health outcomes, or is it more of a structural proxy?
That's a great set of questions. And I've been inspired in my conversations with our mutual colleague, Maria Gleamore, who
Yeah.
you had on the show recently, whose research over more than a decade has really built the case that education is really acting causally to improve health
Yeah.
through a variety of mechanisms. And so it's not just kind of happenstance, it's actually the effect of education itself that's improving health. And so we believe here that, if we had a hypothetical world in which we reallocated those with less than bachelor's degree to bachelor's degree, that we truly would see better mortality outcomes.
Huh. That's great.
And it's
Yeah. And
remarkable, Salma,
yeah.
you highlighted females with a bachelor's degree or higher and their
Yeah.
mortality trends. It's remarkable that in this table that you referred to, that across all causes of death, that group actually experienced a negative excess mortality,
Yeah.
which in this case means that their mortality trends improved despite mortality deteriorating for almost every other group.
Yeah, yeah. That's exactly what I was thinking. That's what was interesting for me because clearly there is something going on right there. So how can we get everyone else to get to that point?
And yet,
Yeah,
and yet,
yeah,
some of that reflects, lower mortality rates from these deaths of despair. That
yeah,
said, there is this countervailing effect of circulatory and metabolic conditions, which are
yeah,
elevated even in that group. And so,
yeah,
that comes back to our earlier point that we all share the same environments in the United States, and we have an adverse food environment and other, aspects of the built environment that are creating poor health in this country, and nobody is insulated from that.
yeah, yeah. I fully agree. And I think just like one question specifically methodological on this, because I fully agree with what you said, but it's interesting. I have another colleague that I asked to also review some of the papers I'm thinking about as we critique them. And their question was like, why did you pick 2006, 2010 as the benchmark, given that that was a time that showed a lot of improvements when it comes to cardiovascular disease and circulatory diseases and metabolic diseases improvements. And if we pick a different period, it might look differently. I want to hear your answer to this, but I didn't think that was a pushback that I was interested in, just because like why aim for a period that had actually like lower improvements? If we assume the improvements were due to advancements in technology and science and just increasing access to clinical tools that would make us live better or structural tools, why compare to a period that wasn't actually getting to those high positive outputs? I don't know if that was your reasoning for choosing it, but that was an interesting critique that I thought, I don't know if it merits that critique here.
No, it's fair, and
Yeah,
with any of these excess mortality modeling approaches,
yeah,
the kind of choice of the counterfactual is a bit arbitrary.
yeah.
But you're asking about what has become a central puzzle in the mortality demography literature, which is why were the 2000s so good, and then
Yeah.
what happened in the 2010s that created this, widespread mortality stagnation. And so there's a lot of unanswered questions about, what were the components of technological progress in the 2000s that improved health so much, and then what changed in 2010 to create an entirely different picture, including stagnation and life expectancy.
So one last question then on this method, because I am interested in seeing how it applies to different questions, is do you think there is a benefit to doing excess mortality by state, given how big the U.S. is compared to other comparative countries? And we had Jose last week who spoke to us about like a lot of the work they do is comparing different U.S. states
Mhm.
with other comparative countries, because U.S. states basically like Sweden is at the size of like one of the U.S. states. Do you think that would be a helpful approach for excess mortality for someone to dig deeper into? Or do you think we actually get the benefit of thinking about the environment, as you mentioned a lot, as a US, as a overall, as a federal environment, that especially when it comes to food environment, that we should take the country as a whole?
Great question. No, I think it's urgent. It's really necessary to dig into state level data, particularly because states are the venue in which a lot of policies are being decided upon and shaped. And so each state is kind of a policy laboratory with different approaches to Medicaid and to taxation around food and cigarettes and et cetera, helmet laws. And so by digging into these models and doing it on a state by state level, we might be able to identify sets of policy factors that are contributing to poor health over time.
I hope that's something your team is working on. Maybe. So then I want to move to another topic that I think you've written about, and we were discussing before we started here. It's a topic that I'm actually struggling with. We had a conversation earlier this week, a convening here at WashU. I don't think they would mind me saying this, but I spoke to Merlin, who's at Columbia University, who's also struggling with this, that we're seeing some technological advancements that will likely have a large impact on population health. Example, GLP-1 drugs. I have been truly struggling with what to make of GLP-1 drugs as a public health researcher, not as a physician. As a physician, I am so excited that this is something that exists. Hopefully, we'll see more data on different outcomes, but I'm really excited. But as a public health researcher, as someone who works on structures and social determinants of health, it's a question of what do we do with it? And I think you wrote a very interesting and helpful article on STAT. So maybe just walk us through first, what was your argument set when it comes to GLP-1 drugs and what should public health do about it? But I also then want to ask about your previous work on obesity and what do you think GLP-1 drugs mean for that type of work?
Thank you. Yeah, as a demographer, I've long been interested in the role of metabolic risk factors like obesity for US mortality trends. And we've written a paper prior to the pandemic showing that rising metabolic risk factors at the population level have accounted for hundreds of thousands of excess US deaths in the most recent period, due not only to increases in things like hypertension and obesity, but also the accumulation of those across the life course. People are living longer with those conditions, earlier onset across cohorts and so on. So we're really worried about those risk factors. And so the GLP-1 era has been interesting to us because it does seem like a game-changing pharmaceutical solution to this challenge. That said, any pharmaceutical solution raises a lot of concerns. Like you said, to those of us who are trained in social epidemiology, sociology, and are interested in social and structural determinants, that the reliance on something like that seems like we're medicalizing something that needs structural solutions.
Yeah. And I think then, at least I think my understanding is in the stat paper, you try to get into some of that. Like what should public health do then? So this is where we are. I'm a social epidemiologist. I'm deeply interested in understanding social and economic policies that shape health outcomes. What would be your recommendation? I know you don't feel comfortable providing generalized recommendations to people, but how should we study or think about GLP-1 as something that gets into our system? I try to think about it as what happened when we introduced statins. I don't know if that's the right approach, just given like how strong or how successful GLP-1 drugs seem to be for different outcomes. But how should we incorporate thinking about GLP-1 drugs now in the environment that people live in as part of our analysis when we think about obesity, when we think about public health outcomes research?
Yeah, thank you. I think, one thing I can say about GLP-1s and where I'm optimistic that they play a role is that, we lack effective obesity treatments, both for obesity, for diabetes and related metabolic conditions. And, we cannot roll out or give bariatric and metabolic surgery at the population level. It's just not something we would want to recommend. And so, for those who are currently living with obesity and other metabolic conditions, that this does have great hope. And structural and social upstream solutions may not, help people who are currently living with these conditions. And so we need to think both about obesity prevention and these upstream determinants, including soda taxes and environmental changes, as well as what do we do for people who are living with these conditions today? What can we do now to help people improve the quality of their lives and their cardiovascular outcomes?
And I think you mentioned being a demographer and a sociologist multiple times. So as I was going through your entire history, and as a disclaimer, I tell everyone, I swear I'm not stalking you. I'm just really impressed with all of your work. How do you think being a demographer and where we met was in a school of public health. So You're in a school of public health as a demographer. What lens do you think that provides to your work?
Well, one lens that provides is that, a lot of the current epidemiological literature on GLP-1s in pharmacoepi is focused on, can we develop emulated trials to get better estimates of, let's say, the hazard ratio associated with GLP-1s versus other treatments? Can we figure out on an individual level what are the potential benefits of these drugs versus other compared, other standards of care, whether it's SGLT2s or metformin or first generation obesity drugs. So that's one of the defining questions in the epidemiological literature. I think as a demographer, what we're interested in is more like, what do these GLP-1s mean for the future of population health and health disparities? What does this mean for mortality trends? Given that there's uneven uptake of these drugs, what does this mean for communities of color and for low SES communities who are not really getting these drugs to the same extent? And so it's those population questions that really animate us more so than kind of getting good estimates of the hazard ratio for GLP-1s versus other drugs in like an emulated trial framework.
So then the last question I usually ask everyone here is, what's a narrative that you think needs to be complicated in public health? Methods, research, questions, and practice. I think you might have a lot of complications you would like to see in public health. So I'll let you pick one.
That's a really great question. Yeah, I think I could say that, since we landed on GLP-1s as the last topic, I would say that, there is a precedent for incorporating pharmaceutical solutions into public health, into balancing the downstream and the upstream determinants. You mentioned statins. And of course, we've all come to embrace antiretroviral therapies for HIV/AIDS. And so there are examples of where we can complicate the narrative and say, there are ways to combine the downstream and the upstream approaches together into an effective public health solution.
Thank you, Andrew.
Thank you very much, Salma, for having me today.
This episode was edited by Catalina Melendez-Contreras, with marketing and outreach by Kinkini Bahaduri. The podcast is supported by the School of Public Health and the Frick Initiative at Washington University in St. Louis. You can find Complicating the Narrative wherever you get your podcast, and you can also watch the episodes on YouTube. If you found this conversation useful, rating, sharing, or recommending the podcast is one of the best ways to help us reach more people. Thank you for listening.